I go back to Amit for a second, and you brought it a little bit, but let's dissect it a little bit further. Cholangio plus hepatocellular carcinoma, this entity.
Yeah, so we're seeing this more and more. So, we used to think of HCC and cholangio. I mean, they're both primary liver cancers, but we thought of them as like two distinct diseases. And I think more and more we're starting to see that it's really probably a spectrum. And as biopsy is starting to be used more and more, even for HCC, in our clinical practice, we're seeing more and more of these mixed tumors. And I think you see some that are predominant HCC with a touch of cholangio, and then you see some that are predominantly cholangio with a touch of HCC. I think it's going to be an interesting time because those mixed tumors, I don't think we really know exactly what the optimal treatment is. And I imagine it really depends on what your predominant tumor is within each of these. But we do see more and more mixed, and at least in our clinical practice, this is why we become much more prone to biopsy, even things that may have characteristic imaging.
Fascinating. Talk about biopsies. I'll go back to Farshid. And patient with cholangiocarcinoma, certain set of mutations progress. Another repeat biopsy?
At a minimum, I would say a liquid biopsy. As Riyad already alluded to, tumors are dynamic. There's new mutations emerging, resistance mutations. So we do try at a minimum, if we can't access the tumor for whatever reasons, for safety reasons, do a liquid biopsy. Now, these tests take time to come back. This is an aggressive disease, Amit said, so you want to do your homework early on. So we do get early profiling, but upon progression, at the minimum, we try to get a liquid biopsy to see if there's any emerging mutations that might be targetable that were not in the original tumor. If feasible, obviously, we would also do a tissue biopsy.
I like what you said because, interestingly, there is data actually, and I'm sure you're well aware of, that came out of MGH, really quite a very nice piece where patients with FGFR2 fusions that progressed, it's fascinating. This is like where they actually had a stat autopsy collection of tissue from the liver and find out the different locations of tumor, what are the changes in regard to the genetic mutations or the genetic fusions. And it's quite fascinating that really, yes, these changes do occur. We're not necessarily vouching for make sure that we re-biopsy everybody. Ultimately, the science of it still need to be evolving. At the moment, actually, pathologists will tell us that it's not like everybody will have an alteration in regard to their genetic makeup of the tumor, but nonetheless, we're learning more and more about this. And the quite fascinating part about it is it really something that happened by random, i.e. it changed from one mutation to the other, or there's a certain kind of, phenomenon that will really make a tumor stressed enough to really alter to a different mutation. Time will tell, and we'll see how it's going to take us from there. Go back, however, to the FGFR2. Some of our colleagues get a little bit nerved up about the anti-FGFR2s because of the side effects. What are the things that you're mostly worried about, and thoughts?
So retinal serous or serous retinopathy is something that you need to pay attention to. That means closely working with an ophthalmologist or an eye doctor, referring the patients, and it's manageable. Again, you have to hold it, let it resolve, and then you can actually restart the patients. That's something, you look at their labs, phosphate level, hyperphosphatemia is a very common side effect. Again, with sevelamer and other phosphobinders, you can manage that. There are some skin and nail changes that you look for. So there are side effects that you have to be aware of, but again, you have to closely monitor the patient and work very closely, I think, with the eye doctors at a minimum to manage these main side effects.
I think hit all the three key ones, which is, if anything, hyperphosphatemia and the skin nail changes and the retinal changes. And if anything, close monitoring will be key. It's quite fascinating, though. Hypophosphatemia was also noted, but the best understanding we have is that really was physician-driven. If anything, really, we were so excited about the hyperphosphatemia enough that we caused a hypophosphatemia. So if anything, we're not really or should not treat numbers, but rather treat symptoms. And this is really where very important to really get a better understanding about the management of those symptoms per se.